Okay, hi. We're going to talk about those autorhythmic cells of the heart in this lecture and possibly get to EKGs, at least in kindergarten form, EKGs, not real world. You had to be trained on that stuff. Okay, so for the cardiac conduction system, these would be those autorhythmic cells that I mentioned in a previous auto lecture. They're cells that are not contractile cells. They are cells that produce electricity. Sorry, I'm trying to manage my screen. We're trying to produce electricity. And so the heart itself, I said, if you remove the heart from the body, it will still continue to contract, despite the fact that you've severed it from the autonomic nervous system. Remember, in the autonomic nervous system, and this will come up also later in the lecture, we have sympathetic fibers, and those sympathetic fibers innervate the heart. And we have parasympathetic fibers. The sympathetic fibers are fight or flight. So that's when you're going to be and get exercise, afraid, etc. The sympathetic fibers will take over. And of course, they would cause your heart to beat faster. And the parasympathetic fibers, those fibers, when they're innervating, like the organs, they're rest and digest. And so if you're nice and calm right now, your parasympathetic nervous system should be in control of your heart rate. However, where does the heart rate begin from? The sinoatrial node, these cardiac conduction system, these autorhythmic cells, they're groups of cells that are unstable and they're just going to be firing off action potentials. And we actually call them pacemaker potentials instead of action potentials because they're setting the pace of the heart. They're being modulated by the sympathetic and the parasympathetic nervous system. But let's do this. Here's the heart, and here's how I would have taught it, that there's a pacemaker in the heart that we're about to learn about. There's a pacemaker in the heart, and it's firing off action potentials. And when it fires off action potentials, then the whole heart will contract, the heart will beat, etc. But we have parasympathetic fibers coming in saying slow down, and we have sympathetic fibers coming in saying speed up. So which part of the autonomic nervous system will win? Well, whoever needs to be in control. If you're in fight or flight mode, the sympathetic nervous system will take over. If you're in rest and digest mode, the parasympathetic fibers will take over. It's really important understanding about this dual innervation. Dual innervation, because we have two branches saying conflicting things, two branches of the autonomic nervous system, one saying speed up, one saying slow down. Now, pretend like we're not even talking about the nervous system, and we'll just go straight to those autorhythmic cells. There are groups of autorhythmic cells, and collectively they're called the cardiac conduction system. And the big important one to remember, well, they're all important to remember, we have this thing called the SA node. Please know that SA node stands for sinoatrial, and this is going to be found in your right atrium. So hopefully you know your heart anatomy by now. It's going to be found in the right atrium, and it is, when I'll teach you about pacemaker potentials here in a second, but it's firing off these action potentials, and it stimulates the cells around them, and because the heart acts as a functional syncytium, every cell will contract. So an average SA node might be firing off 60 to 100 action potentials per minute. And if it does, what that translates to is if it's doing 80 action potentials per minute, then you have 80 heartbeats per minute. So it's straightforward. This is the electrical part that actually causes the cardiac myocytes to contract. Okay. So our SA node is what we officially call the pacemaker. And I'll tell you why in a second. If the SA node is in control, then we say that the patient is in sinus rhythm. They have sinus rhythm. The pacemaker is, we'll see in a second. The next group of cells, this big group of cells, these are internodal pathways. Electricity will be sent down these guys, but these are the ones that are important. The sinoatrial node, these pathways are important too. But we talk about the atrioventricular node, and this AV node is only firing off 40 to 60 action potentials per minute. So this guy, let's pretend like he's sending off 80 action potentials per minute. That means the heart rate's going to be 80 beats per minute. This guy, say, is doing 50 action potentials per minute, just firing off these action potentials. And so what does that mean? The heart's beating 80 beats a minute, 50 beats a minute. We'll continue on with this. This bundle of his right here. This is going into that interventricular septum, and it's going to carry down to the right bundle branch and the left bundle branch up to these things called Purkinje fibers that go up the outside of the heart, and they innervate like the papillary muscles. So we have the bundle of his, just this narrow region here, going into that, piercing into that interventricular septum, and then it separates into the bundle branches, and then it leads to the Purkinje fibers, which are firing off action potentials. I'm making up these following numbers just to give you an idea, but say the bundle of his is, it can fire action potentials at a rate of, it's going to fire off at a rate of 30 action potentials per minute. So you'd have 30 heartbeats per minute. And we'll get down to these Purkinje fibers and say that they fire off 10 action potentials per minute. So how confusing is this? Everybody's firing off different amounts of information, different electrical signals. So what's the heart rate going to do? Well, whoever is firing off the most action potentials per minute wins. That is your pacemaker. Now, in a normal, healthy heart, of course, that's going to be this SA node, the sinoatrial node. But sometimes something happens with the sinoatrial node, and the AV node, because it's the next highest producer of action potentials, it's going to take over. And if it does, if the AV node takes over, you can have fewer heartbeats per minute. That should hopefully be obvious. But we would say that the patient is in junctional rhythm. And we're going to see EKG strips, like kindergarten form EKG strips, here in a little bit. And I'll show you what sinus rhythm compared to junctional rhythm looks like. Now, obviously, if this guy is busted, the sinoatrial node, and the AV node, it's busted. If we get down here to the bundle of his and the bundle branches and Purkinje fibers, they're not going to be firing off enough action potentials per minute to sustain life. Can you imagine if your heart rate were 30 beats per minute? That would be horrific, right? And so when things go wrong with this cardiac conduction system, that's when patients end up with pacemakers to make sure that their heart actually keeps beating as many beats per minute as it should to maintain cardiac output, basically. Okay, let's see. Let's see what's on the next page. Same picture. It was better than the one in the textbook was a little too small. And so imagine this, the action potentials, most of them are going to be started here because these guys can still produce action potentials. Everything in yellow there, think of it as nervous tissue, but it's not nervous tissue. It's not like part of the autonomic nervous system. It's part of the heart's cardiac conduction system. So those cells are not contractile. They are the autorhythmic cells, and they fire off action potentials called pacemaker potentials. So this is, these are just, we've already said all of this. The wave of electricity passes to, yes, causes, this is just a repeat. So let's look at pacemaker potentials. We know an action potential in skeletal muscle and in neurons looks like this. We know an action potential, just the shape of it in cardiac muscle looks like this. We're going to find out a pacemaker potential looks like this. One, and then another, and then another, and then another. It doesn't really look like this because they're different things creating the electricity for these pacemaker cells. I wish I were had good stuff to teach with. And I don't know where the good stuff is, those professional people out there. Okay, so this is actually what a pacemaker potential looks like. What we have is we have an unstable resting membrane potential. So normally you'd have a resting membrane potential, and then you'd have a stimulus, and then it would reach threshold, and you'd go into depolarization. Well, what's happening here is we have sodium is just leaking in here. So sodium is leaking in, causing a depolarization of the cell. That says leaking until we reach threshold. Well, as soon as we reach threshold, then calcium gates open. So it's really calcium causing the depolarization in these pacemaker cells. told you before how important it is to maintain blood calcium levels. So you have proper functioning of your nervous system, proper functioning of the heart, the cardiovascular system, blood clotting, pretty much everything. You have to have calcium is a very important ion. But here in these pacemaker potentials, they actually cause the depolarization. And then again, potassium always causes repolarization to take that cell back to normal. Now, the thing about this is the clunky part. I have to clear my drawings, then I have to close this, and then I have to do this, and then I have to do this. There we go. Here are several pacemaker potentials in a row. Notice that we have, I wonder if you can see my little my drawing. Yeah. Notice on this side, we're going up. Here's where we're starting. We'll start right here. We're going this way. This is sodium leaking in. Once we reach threshold, bam, depolarization. That's from calcium. And then we repolarize, and then sodium leaks back in, and repolarization is potassium. And so we don't need a stimulus, is the point, for these autorhythmic cells to fire off electricity. It doesn't have to come from the nervous system. It doesn't have to come off anywhere. They're just unstable. They're just sodium leaks in till you reach threshold. Now, this is a little out of order, this slide, but I'm doing this because this it seems like a very hard transition. The term systole, when you hear the term systole, that means contraction of the heart. And if you hear the term diastole, that's relaxation. And so we have this thing called the cardiac cycle, everything that happens in one heartbeat. Well, you have blood flowing into the atria, and then the blood's going to passively flow down into the ventricles through the open atrioventricular valves. And at that point, when blood is flowing in to both this right, and I'm not going to do it through the blood vessels, and left atria, when blood is flowing into them, they are relaxed. They are in atrial diastole. And then I said the blood passes through just passively and starts to fill up on both sides. Dun, 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 starts to fill up on both sides. So atrial diastole is occurring at the same time as ventricular diastole. So the atria are relaxing, blood's coming in, flowing straight down to the ventricles that are relaxed. So atrial and ventricular diastole are occurring at the same time. And then the atria, now the atrial systole and ventricular systole do not occur at the same time. The atria are relaxed, blood's flowing through them, just straight down into the ventricles, pressure's building up in the ventricles, and the atria give a little contraction to squeeze the rest of their blood down into the ventricles. Well, after atrial contraction, which is called atrial systole, then the ventricles will contract. And we want them to contract at different, atria first, then ventricles, because we want to contract and send. See, here's atria contracting. This is atrial systole, sending that blood down this way. And that atrial contraction, by the way, is caused by this. Here's the SA node. Here's the AV node. Here's that bundle of the bundle branches, Purkinje fibers coming up in the papillary muscles. And so the ventricles were relaxing. And when the ventricles receive their electrical signal second, because we always start up at the top with this cardiac conduction system, when it goes down through the bundle branches and around the Purkinje fibers, then we're going to have that ringing contraction of the ventricles called ventricular systole. So these are two important words for you to understand. When we go over cardiac output in the next lecture, we're really going to be talking about ventricular. We're going to focus on ventricular systole and diastole because it's going to be major measurements for your blood pressure. Okay, so remember those terms. And what are blood pressure? If you have 120 milligrams of mercury over 70, what do you call the top number? The patient's blank pressure, what do you call the bottom? Systolic and diastolic. Systolic blood pressure and diastolic blood pressure. And these are really going to be the pressure that the aorta experiences during left ventricular systole. And this is going to be the pressure that the aorta experiences during left ventricular diastole. And so know these terms. Okay, let's do an EKG. Keep in mind that I'm a biologist. I am a biologist. And so if you really want to know about EKGs and how to read them, you're going to need to take a lot of training, like the paramedics and the EMTs, etc. This we call kindergarten echocardiography. Echocardiography is a graphic recording of all the action potentials that are occurring through the heart. So it might look a little similar to an action potential to you. Please review the last lecture. If you don't know what an action potential looks like, it may look a little similar, but it's not. So an electrocardiography is a graphic recording. What comes out of the machine is an electrocardiogram or an ECG, cardio, EKG, same thing, cardio, Greek or Latin. Now, these are the things we're going to focus on, what's called the P wave, the QRS wave, and the T wave. And these come in order in the alphabet, LMNOP, QRS, T. That's how you remember what goes first. P wave is going to come first. When you see the P wave on the recording, that means if you see a P wave, that means both atria were depolarized. If you see atrial depolarization, this means the atria contracted, because this is the electricity. So that tells us if the electricity went through, then we're going to have atrial contraction, atrial systole. Oh, yay, the atria contracted. If we see a QRS wave, then we know that the ventricles were depolarized, meaning sodium's rushing in, and in this case, sodium, and it's going to be calcium, but sodium's going to be rushing in. We get ventricular depolarization. If we see ventricular depolarization, we can assume, hey, guess what? Then the ventricles contracted. We had ventricular systole. Now, T wave, you always know on an action potential, these are going to be, this is not an action potential that we're seeing, but the words depolarization and repolarization do go right back to the action potential. The ventricle cells have to repolarize. And to repolarize, remember, then that means that potassium is rushing out of the cells. And on an EKG, what that represents is a T wave. If we see a T wave, proper T wave, then we know the ventricles repolarized to get ready for the heart to contract again. So let's take a look at this. Here's our little P wave. We're going along here. This first bump is our P wave. P wave. That means the atria were depolarized. Yay! That means the atria contracted. Like we did at the beginning of this, atria contract, send blood down to the ventricles. What's going to happen next? The ventricles are going to contract. So here we see this QRS, the very big deflection wave going up and down. That means that the ventricles depolarized, and then so therefore it means the ventricles contracted. And then over here, the ventricles always have to repolarize afterwards, so we have this T wave. This represents ventricular repolarization. Well, if you're thinking the ventricles depolarized and then they repolarized, atria depolarized, where's their repolarization little blip? Well, you can't see it. It would be around here, but it's eaten by this big, huge QRS complex. So that is where the wave for atrial repolarization is. Nowhere. You won't see that on this graph. So here are some EKG strips. Now, the units are gone. Again, this is kindergarten EKG learning here, but here's how I would go about figuring out an EKG strip. And there are going to be lots of leads on a person, so you have to know which strip to look at. Whoops, hold on. This guy right here, this big tall thing, can you imagine that this is a QRS wave? If you can, that's ventricular depolarization. If there's a bump just prior to it, that's P, that's atrial depolarization. So the atria contracted, the ventricles contracted, so that this must mean that this is T, P, QRS, T. So let's go QRS, go back one, here's P, QRS wave, T. So what we're seeing here is before every QRS, we have a P, and after every one, we have a T. P, T. Everything's hunky-dory here. This is a heart that is in sinus rhythm, meaning rhythm. It's in sinus rhythm, meaning that SA node is in control. Everything is fine. It's firing off action potentials. The atria are contracting, the ventricles are contracting. The atria are contracting, and the ventricles are contracting. Now down here, what we see, here's our QRS. If we go back one, we don't see anything here, but we do see this bump here. We always see this bump afterwards. This is that, well, not always. Let's see. And here's our T wave. So here's the ventricles are contracting, and then they're repolarizing. But what are we missing? We're missing this P wave. Same with this next one. We look here, QRS, T, QRS, T, but we're never seeing any P waves. So the P waves, remember that the atria contracted. And if we're not seeing atrial contraction and just ventricular contraction, what's happening is the blood's coming into the atria down to the ventricles contract, but the atria never do. And that goes back to, this is junctional rhythm. You get a slower heart rate because which autorhythmic cells are in control? I hope you said at the AV node. What's happening here? I'll get back to it. This guy is not sending out action potentials up here in this right atrium. This is right at the border of this interventricular, between the atria and the ventricles. And so all the action potentials are just going down here. And so if you can imagine, this is the atria up here, and these are the ventricles down here. If our SA node is not firing, then our atria are not going to contract. But the ventricles will. Is that going to kill you? No. In junctional rhythm, you can get a slow heart rate called bradycardia. Fast heart rate, by the way, is tachycardia. But if you have bradycardia, then there is a chance that you're not getting blood fast enough around to your body and up to your head. And so if you're symptomatic, then that's time for a pacemaker, I would assume. Now let's look at this strip down here. We see our QRS waves. Those are the biggest ones. Now, if we go back, look, there's a P. I'm not going to do the QRS. Here's our T. Here's our bump, T. I'm going to do Q. And then, so if this is a T, let's do this one. QRS. Go back one, P. Go forward one, T. Here we go. Boom. QRS, you get the gist. There's an extra bump here. What is this extra bump? It's not an extra bump. Something's actually missing here. What we should have is this T wave. Now we have a P wave. So the atria are contracting, but want art. We're missing a QRS wave. Missing a QRS wave. Here we're missing a QRS wave. So what's happening is the atria are beating faster than the ventricles. So maybe we have 2 atrial contractions to each ventricular contraction. We can actually count them on the CKG strip. 1, 2, 3, 4, 5 ventricular contractions. So that's our rate for the ventricles contracting. Our atria, we'll just assume one over here. 1, 2, 3, 4, 5, 6, 7, 8, 9. So the atria are contracting 9 times while the ventricles are contracting at a much slower rate. So what's happening here? This is a form of heart block. There are lots of different heart block levels. So don't think that you know things by this lecture. You got to do the training, right? So on heart block, what's happening is if the atria are contracting more than the ventricles, that means not all of the messages are getting down to the ventricles. So how does that happen? I said that the heart in previous lectures, that the heart contracts as a functional syncytium. So if one cell contracts, they all contract. That was a little hyperbole. really between the atria up here and the ventricles. Think of these atrial cells and the ventricular cells as not being connected at all. So the only way we get electrical message from the atria to the ventricles is through this AV node here. AV node taking messages down into that interventricular septum. And so there's a blockage somehow. Don't think of it as like, I mean, a true blockage, but what's happening is some of the messages are getting through to the ventricles, some are not. And so that's called heart block. This last one, this bad. This is bad. We're not mentioning, this is not there are so many different strips and so many different problems like atrial fibrillation. Fibrillation is like your heart's like squirming like a bag of worms. Well, atrial fibrillation is not nearly as bad because people can walk around with AFib, right? As this guy down here. This is ventricular fibrillation, and most people who work saving lives when they see this on the EKG strip know exactly what this means. This means if someone's in ventricular fibrillation, the heart is just squirming and no blood is going anywhere. So if no blood is going anywhere, guess what? That's going to equal death, right? And so in ventricular fibrillation, this are VFib, extreme emergency, right? No blood's going anywhere and the heart is just squirming around. And so with this case right here, I mean, it's just, like this. And so that is when you have to like charge, pump, clear. You have to zap them, right? With the little chest paddles, using technical terms here. But the purpose of it is to flatline the patient. We want them to go flatline, meaning just go flatline. And what they're trying to do is reset that sinoatrial pattern. They're trying, by going flatline, they're like, oh, I just hope it works. Because if it does, what will happen is maybe that SA node will start firing off action potentials and everything will be okay. So ventricular fibrillation, if you don't flatline someone, they're going to die. They're going to die. And sometimes it works and sometimes it doesn't. But I guess the take-home message is this is super bad. About these EKG strips, there are about 1,010 more. So please, again, don't think you know anything by this lecture, but it's good to have at least a basic understanding of the P wave, means the atria contracted, the QRS wave, oh, the ventricles contracted, yay. And then you want the ventricles to repolarize to get them back to where they can contract again. So there's some important things to look at. Well, this is the last slide of the lecture. So you know the heart, if you listen to someone's heart and it goes lub dub, lub dub, lub dub, lub dub. The heart sounds are actually from the valves closing. And that first lub, that first sound that you hear, are the AV valves closing, the valves between the atria and the ventricles, meaning the tricuspid and the mitral valves first. Interesting, the mitral valve closes first. The left side of the heart's going to close first before the right side. So, but you hear them at the same time, lub, dub, lub, dub, lub, dub, lub, dub. The second sound that you hear, the second dub, are those semilunar valves at the base of the aorta and the pulmonary artery closing. And those SL valves are the dub. The aortic, so on the left side, it closes first, and then the pulmonary valve. But what you're hearing just with your ear is a lub dub. Now, if you want to listen to the actual heart, we did this in one of the first lectures. If you listen in the second intercostal space and the fifth intercostal space, the sound travels at an oblique manner to the chest wall. And so if you want to hear the pulmonary semilunar valve open, listen up here. If you want to learn the mitral valve, you're down here. If you want to listen on the chest to the tricuspid valve, you go down here. And if you want to listen to the aortic valve, you go up here. All right. That's it. And then you can tell which valves have maybe abnormal sounds. What could abnormal heart sounds be? Well, they're called murmurs. That's different than an arrhythmia. An arrhythmia is like one of these guys down here. This is an arrhythmia. Arrhythmia means without rhythm, like without sinus rhythm, for instance. So this is an arrhythmia. A murmur is just an abnormal heart sound, and usually it's blood splashing around in the heart or through the valves, but it can get, most of them are benign, and maybe you don't even hear a murmur on a patient until they get really sick, like with a fever or something like that, and then you can actually hear their murmurs. Most of the murmurs, if they get really bad, you're hearing them because the heart valves are regurgitating, as in, say, the mitral valve. You have mitral valve prolapse. Mitral valve, that's the valve between the left atrium and the left ventricle. If you have mitral valve prolapse, what it's doing is when the blood comes from the left atrium down into the left ventricle, when the left ventricle contracts, we want this chordae tendineae to really hold on to that mitral valve so they don't blow back up. In mitral valve prolapse, what's happening is one of the valves comes up a little bit and you regurgitate blood back up into that left atrium. Mitral valve prolapse can be, you might be asymptomatic, or it can be really bad to the point where your heart, your left ventricle is pumping that same unit of blood over and over and over again, and it can fatigue the heart. And so murmurs, usually no big deal. Obviously, doctors, nurses know when murmurs are a big deal. Okay, so the next thing that we're going to do, the next lecture, is going to be the cardiac cycle. Well, we are definitely done for right now.